I started working with KODA almost immediately after I returned to the University of Louisville on the faculty in 2002, and I guess sort of formally took over a role as an intensivist and sort of the assistant medical director probably about 2006, 2007. Started working a little more formally with the organization, and then I became the medical director 3 years ago. Donor families are usually very satisfied with their decision to donate. It helps them bring some good out of what has been a bad situation. And when you ask families who chose not to donate, and you go back and ask them months or years later about that decision, over half of them wish they had have. It may not be for every family, and I understand that. Likelihood it is for most. And that's the educational mission that we have to get out there. More recently, the Center for Medicare and Medicaid Services, CMS, is now asking OPOs like KODA to have their own brain death policy. And so we've recently completed a several month long process of developing a policy very similar to the ones that are in most of our partner hospitals. And in fact, they've said to us that it's our responsibility to help those hospitals develop policies that are accurate, that are up to date, and that follow current medical standards. KODA has tried to find an appropriate policy that meets current medical standards that can be used as the most restrictive policy in hospitals who may have current policies that are not really up to current medical standard. Most of these guidelines are based on things that come from the AAN, which is the American Association of Neurology, and they produced a white paper a few years ago that went through the entire declaration process and talked about the strength and weaknesses of each portion of the exam and of what people commonly refer to as the confirmatory testing. And so we've gone through that document. We've gone through several of our policies in our hospitals, from really tight policies at some of the academic medical centers to some more vague policies at some of our smaller hospitals who may not do donors very often. And we've tried to strike a balance of what would be the most acceptable medical standard. That policy is available to any of our partner hospitals if they want to choose to adopt it and just use it as their brain death policy so they don't have to reinvent the wheel. But at the same time, each time we evaluate a donor for potential organ donation, they're going to be declared by whatever we deem is the most restrictive policy, the hospital's policy or the brain death policy that KODA has created. We created that with several discussions and meetings using a whole host of physicians and stakeholders from our Clinical Affairs Council. So one avenue of our policy is if during the history of the patient that we obtain from the family or that we obtain from the medical personnel taking care of them, there is suspicion that this is an overdose-related death, or if the tox screen is positive for one agent or another that's illicit, there could be other agents that we're not testing for. Most of our overdoses nowadays tend to be multi-drug induced. There are currently 100 or more street drugs that are not tested for in current hospital toxicology tests. These new synthetic forms of heroin and fentanyl that are on the market are laced with many other drugs. Bath salts are very common now, as are some of the other sedative hypnotic drugs. These are known to mask the clinical exam and sometimes even confirmatory testing for our donors. And so in those situations, we're going to ask for a nuclear flow study, which is considered to be one of the better confirmatory tests. We have to be sure. We have to be sure that there's not a drug on board that we can't test for, so we can't know the half-life of, that could suppress our exam and make an inaccurate diagnosis. It's all about safety. You know, drugs has always kind of been our big concern. And I've always worried about the overdose deaths because those are the case reports you see in the lay literature about awakenings after someone's been declared. These are rare events, and I would argue that if one were to carefully review the chart, that probably some missteps were made along the way in the declaration. There are other things other than just overdoses. Profound electrolyte disturbances are a big problem. And many of these patients, you know, for one reason or another, may have real swings, high or low, in some of their electrolytes. The most common is sodium. Other things are hypothermia. Now, with the advent of hypothermic protocols at nearly all of our hospitals, if someone has a witnessed arrest and then is brought back with, you know, CPR or ACLS protocols, hypothermia is a known inhibitor of a good neurologic exam for brain death declaration. So having some guidelines and some so-called guardrails about what would be acceptable ranges for certain electrolytes and for temperature is very important, you know, in the clinical exam for brain death. We try to not interfere in that declaration process, but at the same time, we don't want to have to go back and say, well, we'd really like this test to be sure that the declaration was wrong. That really undermines the trust in everybody. We're not doing this to be more difficult. We're doing this to be more safe and to make sure that we're following the accepted national standards for brain death declaration.